Now let's talk about the clinical features, the various signs and symptoms which are the presenting hallmarks of the chronic myeloid leukemia. The more common symptoms are the most generalized symptoms, which we also had in the AML, and which are mostly common to most of the malignancies concerning the hematological system. The patient will have anemia. The anemia will generally be a normocytic normochromic anemia, which we saw also in the AML. But if the tumor goes into an acidotic phase and there is an increased production of the cells, then because of the deficiency of the folic acid, because it is being used up in making up the cells, the anemia can also transform into a megaloblastic anemia. So generally it's a normocytic normochromic anemia, but it can also have some component of the megaloblastic anemia. The patient will have splenomegaly on examination, as we just talked about in the previous part. Spleen is enlarged. There is a huge enlargement of the spleen. It can all go as large as around 15 centimeter below the costal margin. So splenomegaly is a very important hallmark of CML. And any patient which has unexplained anemia and a large spleen, you should have CML, especially if it's an adult patient. You should have CML in your differential diagnosis, pretty high up in the list. Moving forwards, because of anemia, the patient will have generally low energy, there will be fatigue, malaise, there can be significant weight loss as the disease progresses, and there is some early satiety and the left upper quadrant pain. This is because of the massive spleen. The spleen can push on the stomach and it can go into the abdomen, which can lead to an early satiety. It can also present as a left upper quadrant pain, because when the spleen grows and if it outgrows its blood supply, that can be very painful, and it is also palpable as a big mass on the left side of the abdomen. Certain other less common features, these are generally related to the thrombosis. In patients with CML, we generally have thrombocytosis. The platelet count is generally increased, especially in the early part of the disease. Because of that thrombocytosis, we have a procoagulant state in which there is an increased chance of thrombosis. As the disease progresses, as we are going to see as we move forwards into the accelerated and the blast crisis, we are going to have both pictures, the bleeding diathesis and also the thrombotic pictures. But earlier on, in the chronic phase, the less common features, because of the thrombosis and increased incidence of thrombotic events, we might have priapism in patients. This is because of the occlusion of the blood supply to the penis. Also, we might have certain cardiovascular complications. We might have angina or coronary artery disease if the arteries are affected, if there's a thrombus formation there. It can also be as bad as leading to a myocardial infarction in certain patients. You might have certain venous thrombi presenting as the DVT or the deep vein thrombosis. If the retinal veins are involved, it can lead to visual disturbances. It can also lead to the retinal hemorrhages. Certainly, if we have a pulmonary artery involvement or other involvement of the pulmonary tree, that can lead to dyspnea. It can be an exertion, and if it is very bad, it can be at rest as well. Pulmonary insufficiency can be there, which can also put a strain on the right side of the heart, can eventually lead to right-sided heart failure. If the CNS is involved, then we can have varied presentations. The patient might have altered sensorium, like drowsiness or vertigo. There can be loss of coordination if there is a cerebellar involvement in these patients. Confusion can be present if there is a global cerebral ischemia, or also various types of strokes or cerebrovascular incidents. They can also be present. This is the hallmark of mostly the thrombotic events, and these are mostly evident when the disease is very progressive or the disease quickly moves onwards into the next phases. All of these symptoms can be explained on the basis of the increased thrombotic complications, but all of these symptoms can be found out in a lot of other diseases. So that's why it's very difficult to clinically diagnose CML, and we have to, because the generalized signs and symptoms and the generalized features are very non-specific. You don't have a specific symptom. Maybe splenomegaly, massive spleen, can be a specific symptom of CML, but generally the symptoms are very generalized and they can be found out in a lot of diseases. So that's why we have to rely on along with our clinical judgment, we have to rely on the various diagnostic tests, which we're going to talk about in the diagnosis section. As the disease progresses, along with the thrombotic events, we can have a bleeding diathesis because of an increased number of platelets, but they are as the number of platelets increases with the disease progression, the platelets can be basically useless, so they can be the platelets which do not do their job of plugging the arteries very well. So we have an increased incidence of the bleeding diathesis in that case. So in those patients, they can present us to us with retinal hemorrhages, especially if they have underlying problems like diabetes, mellitus, or hypertension. They can also present to us with a GI bleed. And then there are certain additional symptoms which are more specific to the accelerated phase of the disease. What happens is that there is unexplained fever, or the fever can go till higher temperatures. Then we can also have a significant weight loss, for example, in a very short period of time. As the median duration of the chronic phase is around 5-6 years, and when we talk about the accelerated phase, then the disease progresses in months, and then there can be a significant weight loss in a very quick period of time. Fatigue can increase, the bone and joint aches can be present there, and then there can be either a combination of bleeding and thrombotic events, or both of them can occur together. So initially there were more thrombotic events, but as the disease progresses, there can be both the bleeding and there can be also thrombosis. And also there is an increased risk of infections, because the WBCs, although the WBC count will be high, but these are malignant cells. These cells are not effective at doing their job, which is to fight infections. So we might have 50,000 or 60,000 number of the WBCs, but they are not doing the job. So they are basically malignant cells. They don't have any normalcy attached to them. And moving forward in the certain types of physical findings which we have, we talked about the splenomegaly. The spleen will be massively enlarged in a lot of patients. Along with that, we can also have hepatomegaly as well. This is because of when the disease progresses outside of the bone marrow, and when the blood cells and there are blast cells in the peripheral blood film, they can go into the various sites. It can go into the liver, it can go to the liver enlargement, or hepatomegaly. Hepatomegaly can also be because of certain extramedullary hematopoiesis going onwards. Along with that, we will have lymphadenopathy in the later stages of the disease, in the accelerated phase specifically, and also in the blast phase. Generalized painless lymphadenopathy can be there. And because of extramedullary disease, various organs can be affected, be it the lungs, the heart, and the brain. And then depending on the organ system involved, we will have the specific symptoms pertinent to that organ. These were all the generalized signs and symptoms related to the CML, or the chronic myeloid leukemia.